This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organized compartments and customizable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this trio of episodes, we're going to be looking at palliative care and end-of-life care as a mini-series. So this is going to be episode 1, where we really look at an introduction to palliative and end-of-life care. So we're going to start by introducing the team, get their overview as to their work and roles, and then we're going to break down what palliative and end-of-life care really means. We're going to highlight some of the differences in the last year of life and palliative care, and also the role of the generalist versus specialist in palliative care. We're also going to look at where ambulance service fits into the wider picture with palliative and end-of-life care. We're also going to explore some of the key challenges faced with pre-hospital teams, including gaps in education and service provision. We're also going to look at how clinicians identify end-of-life care patients, some of the tools and pathways we can support decision-making, and also how we can improve confidence through better training and education. And finally, we're just going to look at the future ahead, some of the goals and innovations in pre-hospital palliative care, from simulation training to national collaboration to tackling healthcare inequalities, and some of the strengthening partnerships between ambulance services and specialist palliative teams. So I'm joined by Karina and Jody. I'm going to hand it over to you. Karina, I'd just like you if you could just go first and just unpack your experience for us, please.
Thank you. Yeah. So my name's Karina Catley. I am the Macmillan Paramedic Lead on the end-of-life care team at London Ambulance Service. So I started on the team back in 2018 when it was first formed, and it was Macmillan funded, which I think we're going to get into in a little bit. And I started as the evaluation lead, so a paramedic by background, but joined the team as an evaluation lead, and then have progressed from there. And it's very exciting now that our team is now paramedic led, and we've got a brand new team for this year. So a bit of a restructure, and Jodie's been on our team for a number of years as well.
So yeah, I'm Jodie, also a paramedic by background. I've been with the LAS my whole career for 20 plus years, and yeah, joined the team 18 months ago. So yeah, I'm now Macmillan Paramedic Associate and working alongside Karina, and we've got 2 other colleagues with us.
Yeah, so we have another Macmillan Paramedic Associate, and we've recently employed a clinical nurse specialist in palliative and end-of-life care that gives that kind of speciality to our team, which is really vital.
Yeah, it's really fascinating to see actually this MDT, this multidisciplinary team approach, which is fantastic. And as you said, paramedic led, which is also fantastic, really. There's real ownership in embedding within the ambulance service, which I think is key. And Karina, I'll come to you first, actually. And could we maybe do a deep dive, really, and a brief explainer as to what palliative and end-of-life care is, maybe just looking at just the differentiators, if you would, and Jodie, please feel free to chip in as well.
Yeah, absolutely. So I think it's really important to define palliative and end-of-life care, because they are 2 different things. So palliative care is the concept of holistic care for a patient with a life-limiting condition. So it's about looking at that patient as a whole, very much about patient-centered approach, and not just looking at them and their illness and their symptoms, but actually looking at them as a whole person and all of their life that surrounds that. So it's kind of like an approach to care that can be delivered by anyone that's involved in that patient's care in various forms. Whereas end-of-life care is a bit more specific in that it relates to the final 12 months of a patient's life. So where a person is likely to die within the next year, that is when we class a patient as end of life care, and that can also relate obviously to the final weeks and months of life as well.
So it's quite important to differentiate when we're on scene and talking to palliative care teams or whoever we are liaising with, is to differentiate, because palliative care doesn't necessarily mean that you're end of life. And I think that's a common misconception. And another common misconception would be that palliative care only would come into play at the very end, in someone's illness, and particularly relating to things like cancers, when actually palliative care is vital for anyone living with a life-limiting condition. And those are often your organ failures, which is what we see a lot of.
Yeah,
frontline and pre-hospitally.
I think that's really key. Absolutely. I think palliative care specialist teams can dip in and out of patients' care as well. I think a lot of people think, as Jodie said, palliative care is just for the dying patients. We're actually things like patients like COPD, where they've got complex symptoms, they can pop in their care, manage that, and then discharge that patient back to their generalist team. So yeah, I think that's a real big misconception.
And we see that a lot, don't we, when we're on the road? We're often like, oh, this patient's been discharged from palliative care. And that's a real misunderstanding from frontline clinicians. So we need to know that palliative care, can start. And as Karina says, that it dips in and out, because the palliative care teams provide such excellent care in that holistic care. And it's not always needed.
Yeah, I think that brings us on to another real key learning point for us. I think certainly what I discovered quite early on in my career, and something that we are constantly sending the message out about, and every kind of debrief we have this conversation about generalist versus specialist palliative care, which I know you mentioned at the beginning of the episode. I had an experience when I was very newly qualified, I think under a year qualified as a paramedic, where I'd attended a patient in a supported accommodation, and she was there. She was actively dying. I was able to recognise that. Very peaceful, actually had no symptoms. I think the carers had called us just because she was now kind of unresponsive. And I remember being really shocked that this patient wasn't known to a specialist palliative care team. And I remember being quite angry, actually, saying, this lady's dying, why isn't a specialist team involved? And it wasn't till kind of I went back and had a chat with some colleagues that actually we kind of realised, well, actually this patient didn't need specialist palliative care. They were dying quite well. There was no complexity within their symptoms. So actually the GP and district nurses could very well manage this patient. And I think that's that misconception that specialist palliative care, these hospice teams, community palliative care teams, need to be involved in every patient that's dying. Firstly, that's not logistically going to happen because of funding, but secondly, those are the resources that should be really reserved for those which have some sort of level of complexity. And it's not just complexity in terms of their symptoms, Jodie, is it? It could be kind of social factors.
Family factors. What's going on with them socially, absolutely. He's like you. And that's what people don't realise, that palliative care can really support them with as well, even down to sort of things like funding, which really is so vital when people are now obviously no longer able to work because of their illness.
Yeah, but the vast majority of patients in the final 12 months of life, the end of life, can absolutely be managed by GPs and district nursing teams, obviously if the resources are there, but that's that generalist approach I think you were talking about at the beginning versus that specialist.
So one of the things I'd like to do deep dive into with you both, Karina and Jodie, is really maybe the educational gaps and or challenges that you identify within the trust in relation to palliative and end of life care, and how you've developed these. Something you've just said there, which is really interesting, is around, the generalist approach versus the specialist approach. And one of the key differentiators in my mind would be that the specialist team kind of knows the patient. They've got a rapport with the patient. They've got an enduring relationship with the family and or the patient. And it's so difficult for pre-hospital teams that are coming in fresh, coming in cold to these environments, which are, like you said, Karina, highly complex. They can be really challenging situations. But could I get you to speak to the educational gaps, which you've really started to close and narrow, and that maybe other services could leverage?
Yeah, thank you. Yeah, so I suppose it's worth giving a bit of context about where we started. So we started in 2018 with a Macmillan funded programme for 2.5 years. So previous to that, London Ambulance Service had no end-of-life care team, had very minimal, with all the best intention, very minimal input in terms of education or guidance in this area. So we were pretty much starting from scratch. So what we decided to do was do a bit of a baseline survey of our staff, asking around confidence and areas that they wanted sort of more support in. And the baseline survey showed only about 50% of staff felt confident in their skills and knowledge of palliative and end-of-life care. So that kind of really set the scene that actually staff need a lot more support. In terms of educational gaps, I think when we first started the programme, actually the definitions of palliative and end-of-life care and the knowledge of the services, symptom management, anticipatory medications, all of those kind of things, it was really quite generally lower levels of knowledge and confidence in those areas, as well as, I think, a real fear about making the wrong decision for this patient group. I think it naturally goes against a lot of our instincts as paramedics and ambulance clinicians to see someone that is that unwell, that is actively dying, and not do something in terms of transport them to hospital or do kind of invasive interventions. Obviously, we can do a lot for these patients, but getting people to build in that pause whilst they figure out and gather more information and history, I think that was a real challenge, because culturally that wasn't where we were at the time. So I would say that's probably the biggest thing. Is there anything else you'd want to add about educational gaps, Jodie?
I think, well, building on from the gaps, was the gaps in the services we had to reach out from, and that really aided our education as well. So the gaps we had was originally, I think, was it just one team that we would refer to at the very beginning, and now we've built up sort of 25 plus referral pathways across London, and we've really worked hard on keeping really strong engagements with all the palliative care teams across London, and that allows for us and our crews to reach out to them when they are with these patients, where, like you say, the specialist teams have built that really strong relationship with these patients. They know the history, they know the family, and then we parachute in. But now we can bridge that gap by calling those teams. We have those numbers available to us, and that really increases our confidence in the fact that we're not, when we are on scene, we know we don't feel like we're on our own, because we know we can call these teams for support.
And I think on that point, I think that's really important, is prior to our team being around, I think ambulance clinicians felt like they had to make these really big decisions on their own because there weren't those pathways in place. And we're quite used to, aren't we, working on our own and with limited information and making decisions, whereas actually that has been one of our key messages, is shared decision making is so key. You don't know these patients, you don't know their background, and actually, as you rightly said, they're often complex situations. So that's a real big takeaway point, I think, throughout all of our education.
Absolutely. And just to double click on that, actually, Karina and Jodie, before we move on, Jodie, you made a fantastic point, as in, 25 teams versus one back in 2018. And I remember, being an advanced paramedic practitioner, coming to a 25-year-old in the dying phase, literally hours to live, increased respiratory rates, cancer, metastatic cancer across multiple organs, and not being able to get hold of the end of life care team. It was 4 a.m. in the morning, and often a lot of these complex calls come in out of hours, come in unsocial hours, and actually it can be really difficult sometimes, I think, to navigate, like you said, reach back to these teams. So it's great to have more contact, more variety, and indeed a richer, deeper relationship with these specialist teams, so that you can reach them, I think, at different times of day and night, because often these acute phases and or the dying phase can occur out of hours, out of standard hours, and having, like you said, that support, that reach back, that shared decision making because to your point as well about appreciation of baseline is going to be deviated. There's going to be abnormal vital signs, but it's getting that, as you were saying, Karina, that historic read receipts from actually this is the patient, this is exactly what they've presented with, this is their wishes, and you know, it's giving people a comfortable, respectable death, but having that information at your fingertips out of hours at 4 a.m. in the morning. So I think that is absolutely key. Having those relationships is fundamental to better patient care at the end of the day.
Oh, completely. And it's not, and what they've been brilliant in supporting us is that obviously they're the specialist teams that we have those contact numbers for, but majority of these patients, like we've discussed, aren't going to be under the specialist teams. But what the hospices and these specialist teams are offering us is actually to be a telephone number and somebody we can still call and say, okay, I've got this patient that may not be known to their team at all because there's been no reason to, and we can just sense check, okay, what can I do? Who is the best person for me to reach to? And they can give us real generalist advice because obviously they don't necessarily know the patients aren't under them. But that again can really guide us in, okay, now I need to go back to the district nurse, because as we've discussed, it's really commonly that we don't realise that a district nurse and a GP can help these patients, and that is what they're really good at signposting us, and available 24/7. And we work so closely with them. We've built up really good relationships, and we do lots of shared learning, which we'll go on to discuss later on with them. That's come from the relationships we've built.
And I think just on that point about access to information, obviously the hospice teams or the palliative care teams are an amazing resource, but something that's really developed within our service is the access to information, the access to advanced care plans. So advanced care plans or future care planning are care plans that the patient will jointly make predominantly with their GP or with a specialist team, and it details sort of things like treatment escalation plans, their preferred place of care, preferred place of death, their wishes, preferences for towards the end of life or for their care in those last few even years of life. And we're lucky in London that we've had for a number of years an electronic palliative care coordination system, which is just a fancy word for saying we've got digital access to these advanced care plans that these teams make, which is invaluable. And it was at the time a real game changer for us, because we were very much used to going in blind, not knowing, and trying to gather that information and act as detectives, whereas it was quite revolutionary that we can have access to these digital care plans that help guide our decision making and treatment. We've now got a system called Universal Care Plan that our crews will get alerted to on the way to these patients, and they can access that at the patient's bedside, which really, and we're doing a lot of work, certainly Jodie's doing a lot of work on improving the quality of these care plans, but they are so helpful for that decision making as well, and they also contain the numbers of the teams where they are known. So it's all about information, really. I think, as you said, whether it's with the teams or with their care planning, it's all about access to information to help support decision making.
And it's always as well, like the key thing about universal care plan is putting the patient in the centre. So it's when the patients do become too, or the people become too unwell to speak for themselves, all of their wishes, all of their preferences, we can see that, we can read it, we can still hear that patient and what was important to them, and then act from that. And in conjunction with the specialist teams or the multiple teams that would contributed to this one central digital plan, along with that patient, we are then, like you say, at 2 o'clock in the morning, we are then there with all of that information at our fingertips, which is, like Karina said, an absolute game changer. It's hugely different. It's so important for the patients.
So just looking at, before we move on to maybe future plans, just a couple of questions. One would be around, I'd like to double click on the confidence, really. Have you seen an improvement in confidence with dealing with these patients? But also, I do also just like to ask about just feedback to crews. You know, is there a semblance of governance and or EPCR audit so that you can actually feedback to crews? You know, would you consider this? Did you consider this? Or indeed, just nice job, as in you handle it really well, you access the right services. Is there that feedback mechanism in place, and have you seen an improvement in confidence?
Yeah, I'll take the first bit about the improvement in confidence, because having been from the team from the start, luckily enough to have been with the team from the start, we have seen a massive improvement in staff confidence. So at the end of our 2.5-year project, it went increased. We redid the survey and increased by 15%. And even since then, post our education that we provide as a team, it's up to about 82%, which we are continuously monitoring. So as a team, we really focus on providing bespoke education for a group of clinicians. So you mentioned being advanced paramedics, or our advanced paramedic colleagues, our colleagues that provide clinical support, as well as our volunteers within our service. We provide bespoke education packages to all of them, as they all work in different ways to support this patient group and support staff as a whole. So absolutely, we've seen an increase in confidence, and we are continuing to educate staff, offer CPD opportunities, and we'll talk a little bit more about that in our future plans around education. But in terms of feedback for staff, it's something that we do, and we're always working on improving. So currently we do have a continuous audit that's carried out on paperwork, on documentation of palliative and end-of-life care patients. So that's every other month they are audited on any kind of cases that come down as palliative or end-of-life care, and we empower their clinical team managers to provide feedback and get in touch if they kind of identify any cases that are particularly complex, or from a welfare perspective they need support on, and we'll offer debriefs there. And as well as that, we do regularly do debriefs with staff. We've got quite an open kind of nature about us, that people tend to come to us if they've had a complex job, something that's bothering them, if they've got any questions, and we do always try and accommodate kind of debriefs, especially for the more complex cases. So we are out and about doing that quite a lot, and empowering our clinical team managers that are managing the bulk of the staff group to do that with us, jointly with us as well. So all working together to provide staff feedback and education in that form as well.
Listen, that's fantastic, and like you said, multimodal feedback through audits, but also, like you said, just maybe informally, just being available either by email or indeed by phone to debrief calls. I think is really powerful, because it can really reframe and put a context around things where clinicians can start to think differently when they approach these calls, and get your perspectives, which I think is equally as powerful. A further question really would be, you've spoken to technology enablers actually, Karina, and having the both the iPads, but also indeed having access to a universal patient care records. Looking at tools to identify end-of-life care patients, is there any tools that you use to maybe identify? Because there is patients that slip through the net sometimes that maybe aren't identified, or indeed maybe that there is actually this patient has transitioned from palliative to end-of-life care. Are there any tools you use to identify or capture those patients to really flag them?
Yeah.
Just before, I was going to just pick you up on something you just said then. So you said kind of transitioning from palliative to end of life care, which I would say that palliative care continues throughout and beyond. So I just when we were talking about the definitions and how we use that terminology when we are talking, that palliative care, you don't transition to end of life care. That palliative care would continue right through to end of life, and even after, because palliative care would still support the family after bereavement. So sorry, I just wanted
great.
to...
No, absolutely. No, absolutely. And it's great to pick me up on that, actually, because I think that even in my mind, that's an anchoring bias in my mind about what that would be like. And actually it's not siloed. Like you said, there's overlap and crossover for sure. Could I get you to speak to any tools you use to really identify patients?
I think your point about these patients slipping through the net is really key. I think that's going to become more and more the role of the ambulance service, is being the first kind of clinicians to identify, well, actually this patient is likely in the last 12 months of life. So we do absolutely promote some tools within our service. So there's a couple of different ones. Our preferred one is the SPICT tool, so the Supportive Palliative Care Indicators tool. So this is a tool that helps to identify patients with deteriorating health, and help identify that these patients would benefit from some palliative care intervention, whether that be specialist or generalist. And the purpose of it is to identify people earlier on in those 12 months, because I think what we find all too often is these patients go and go and go until they're kind of actively dying or in the final months of life, and actually they've missed so many opportunities to try and prevent some of these symptoms, to try and improve quality of life. So that's the purpose of the tool. It has been validated in hospital setting and in primary care settings. It's not yet validated as such in the pre-hospital setting, but it is encouraged its use, and it's a really quick, easy tool that we've had really positive feedback from ambulance clinicians about, because it is super quick and easy to use, given that we sometimes have limited information about this and how it works. I'd encourage your listeners to go have a look at it if they hadn't heard of it. But how it works is it just asks you, firstly, you'd be using the tool if you suspected someone was in the final 12 months of life, you had that gut feeling from your interaction with them, and then you look for general indicators of decline. So if the patient has one or more general indicator of decline, you move on to the next bit of the tool, which talks about specific clinical indicators of decline as per their disease progress. So an example of a general indicator of decline is unplanned hospital admissions. That would tick you to go on to the next part of the tool. And then depending on what kind of advanced or life-limiting condition they have, there would be another one or two factors you would need to tick to make you see that this patient was likely in the final 12 months of life, and you need to start thinking about making a referral to the GP, highlighting it to the GP, or potentially if you are conveying them, highlighting that with the ED staff. So an example is dementia frailty patients. A specific indicator of the decline is eating or drinking less, double incontinent, things like that would make you think, okay, this patient is showing a couple of signs that they're in the final 12 months of life, and perhaps we need to be involving the GP more if they hadn't already kind of identified this patient as such. But I think that is absolutely a role that we are going to be doing more and more with the ageing population, with the kind of restrictions around funding for hospice teams and specialist teams, and the GPs being completely maxed out with their workload. I certainly see us having a really vital role in identifying this patient group a lot more.
And the simple, like the question is, this person was to die in the next 12 months. And that's such a simple question that I think we're frightened of pre-hospital. If we're asked that question when we commit and say, well, yes, I think this patient could die, we feel we shouldn't cross a boundary almost, but it is we are so well placed as ambulance clinicians to be highlighting and identifying these patients early. And like what we said, they're not being captured early enough. We are a massively aging population. We are captured, of course, the cancer patients and malignancies, they are captured. It's the organ failure ones that we're not capturing early enough, and they are missing out on really good palliative care that would massively enhance their life. So it is up to us to be using these tools, educating, because they are so simple. They're really easy to use. It's just you're just looking at a couple of little questions and saying, yes, that this patient ticks that box, so it's likely they're in the last 12 months, nothing more than that, and highlight that to the GP so they can start putting the plans in place, start having conversations with the families and the patients themselves that's missed. We're not giving people opportunity to know that actually their life may be coming to an end. And so what conversations do we need to have, and giving people an opportunity to know that and to be able to live as well as they can in their last part of life.
And I think it's important to say that those conversations aren't necessarily something that us as ambulance clinicians should be having. It's the first time we've met them. It's likely not appropriate, but it's that referral, like you said, referring to a clinician that knows them to start the ball rolling on their advanced care planning in those conversations.
Yeah, I think that's powerful actually, because like you said, it gives and to your point, Jodie, it gives the clinician a baseline of appreciation of, okay, and to yourself, Karina, tick, tick, tick. Actually, they are tipping over into what we would consider, like you said, there's still palliative care is ongoing, but there's an appreciation and, like you say, a flagging that can be raised. We'll put that tool in the show notes actually, because I think it's really worth clinicians going away and just really understanding it and engaging with it. And as an analog of a comparison, it's really useful to have this conversation for both an international listenership, but also a national listenership to see how end-of-life care is embedded within a pre-hospital service, within an ambulance service, and the added benefit, because to your point, Karina, around early recognition, catching these patients which fall through the net, and Jodie, to your point about the richness of care that can be afforded to these patients that would otherwise not benefit from these services, that we are the first point of contact in articulation, in signposting, and indeed referrals. So I think it's super important. I think fundamentally it's a vital service which needs to be embedded at the pre-hospital stage of care. So I think it's absolutely fantastic the work you guys are doing. That kind of tees me up really to the last question. Really, we've been going for just over half an hour. I'd like you to both speak, if possible, to the future of plans or goals of improving pre-hospital palliative and end-of-life care. Jodie, if I could get you to go first, maybe, and just speak to some of the future plans and or goals, and then I'll come to Karina.
Oh, we've got so many, haven't we? And yeah, so I think first and foremost, it's constantly got to be education and improving ways. And I'll let Karina talk about the SIMS part, because that's definitely her field of expertise. But yeah, I would say education is foremost, and then it's looking at ways that we can, when we are conveying, or maybe it's looking at sort of ways we can engage with the other stakeholders. So maybe care homes, that's a focus for us at the moment. We're looking at how we can better support those, because obviously the vast majority of the residents within a care home setting are palliative and end-of-life care. So it's seeing how we can improve and support the care homes in a more a better way. Also ED departments, I know there's a few projects underway in London at the moment where they're putting the specialists within the ED department. So when we are then conveying, having those patients identified quickly. So we're working very closely with a lot of the stakeholders so that we can enhance the projects that they've already got underway. But yeah, in terms of the education side, definitely that's your
so it's quite exciting at the moment. We're in a bit of an exploratory phase around simulation for this patient group, because I think what we appreciate is there's only so far you can go with delivering kind of theory education, and having case-based discussions obviously is really important with this group. But a lot of our staff and a lot of our incidents are around things like medication administration, where they have never seen, we've got quite a young new workforce, and they've never seen a MAR chart, a medication administration authorization chart, which these anticipatory meds come with. So simulation is very much a focus for us. We've run 2 successful simulation events already, and that incorporates things like the practical doing, where they perhaps wouldn't have had the opportunity to do that before, doing that in a really safe, supportive learning environment, as well as obviously the real key thing around this patient group is communication, things like breaking bad news, things like navigating those conversations about preferences for care and treatment escalation plans, as well as handing over and liaising with hospice teams or GPs around this patient group. So I think simulation within the next year is going to be a real big focus for us. Another big work stream is around, we've got a national forum group. So we've got end-of-life care, the end-of-life care, nominated end-of-life care leads nationally across ambulance services. We come together in a group, and that's been a real valuable way of sharing what's going on nationally, identifying problems and working on that on a national level. And an example of our recent output is we've just rewritten and submitted it for approval, the JRCALC guidelines, so our ambulance clinician guidelines on end-of-life care, because we recognise when they were first put in, I think it was around the time our team started, just a bit before perhaps, it was very much an education piece because there was nothing out there now at that point around end of life care education. What we've realised now is lots of the services have come up to speed, which is fantastic to see. And actually, we're making it more guidance focused as opposed to education focused. So it's a quick reference tool for people that need it when they're at the bedside with a patient. So yeah, as well as that, continuing our debriefs and involving stakeholders more within our debriefs, I think is really key. GPs, doing those multidisciplinary debriefs and joint education as well.
Joint education, like we said, we've got that fantastic relationships, and often the hospices will say we're more than happy to come along and deliver education. So what we tend to do is that their teams are come along, we'll give a little bit of education about how the ambulance operates, because they often have no idea about how we categorize and triage calls, about how we dispatch, our different grades of clinicians that we have. So we'll educate them on that side, and then they'll speak about the services they offer and what they can bring to the table. And then it's great, then maybe we'll discuss one or two cases where we'll all sit together and say at what point who had what input in this patient, what could we have done differently. And there is always, I don't think we've ever held a debrief or had a discussion where there's not been some degree of shared learning. Every single time we walk away with something else that we need to look at for ourselves in improving our guidance and education and the teams themselves. And I think that collaboration is just
so vital.
So vital.
Yeah.
It's so beneficial. So yeah, the more, I mean, with that takes up a big chunk of our education.
One thing I would like to maybe double click on before we finish, what would be around data collection really, and because data fundamentally is a single source of truth, and you can really move the dial. Even Karina, as you were saying, tracking confidence levels and tracking staff confidence across the service is evidence of improvement, and it's evidence of clinical effectiveness and effectiveness, educational effectiveness. Could I get you to speak to some of the data you're tracking, and how you're using that data to really measure the quality improvement within the team?
Yeah, so I think data has been a real sticking point from us, and I think the problem with that, and I think other services nationally share the same issues, is these patients don't come into our 999 triage service, and there's not a flag to identify them as palliative or end of life care. They often at times won't identify themselves as that, or family members won't identify. So we are very much reliant at the moment on clinicians coding and recognising that. But we do know that the data we have is massively underrepresentative of the population that we serve at this patient group, if we're thinking wider to that final 12 months of life. So we do get some data, and we do monitor the conveyance to hospital, the ED conveyance data. Not obviously a lot of the times it is absolutely appropriate, but from our program, at the end of our program, it's and even now it sits around 10% of this patient group conveys to the emergency department. We don't kind of drill down as to how many of those were appropriate versus inappropriate, but we kind of recognise that there'll always be a level of conveyance needed for this patient group and wanted by this patient group. We have the audit that obviously we track for quality of care and quality of documentation, and that's fed back to on a kind of station-based level. And we also monitor our incidents and quality alerts that come into us from outside teams. So we have a real good idea of some of the themes of the issues that we identify. So a lot of it is around inappropriate resuscitation or inappropriate conveyance to hospital, as well as access to advanced care plans. Those are the kind of common themes that we see within our incidents, that we work really hard with colleagues on debriefs, on education, with our stakeholders. So we take a real multi-pronged approach to improving the care and the experience for this patient group.
Oh, that's fantastic. Fantastic. And just lastly, and Jodie, I'll come to you around sort of national forums that you're involved with, because speaking to the maternity team within London Ambulance Service, you know, they're really embedded at local level, but also national level, really, by making sure there is national guidance and or policy, which is really being pushed forward in this specialist area. Jodie and or Karina, can I get you to speak to sort of any national forums that you're sitting on or driving forward to really, I guess in a way, just bring the conversation forward on a national level?
So yeah, we sit on a national level, and we're really fortunate. So how many members would we say? So we've got representation from most of the trusts across the nation. Obviously, not other trusts are lucky enough to have a dedicated end of life care team. We are, and we appreciate how fortunate we are to be in that position. Other people will always have a representation. We'll come together every other month, and it's sharing what each other's trusts are doing and learning from one another, which is really good. And then we're also involved with Marie Curie on a national level, and they're really keen on engaging with all the trusts to see how we can improve like pre-hospital, palliative and end-of-life care.
And we've got the Ambitions Network as well, which is like a national driver for improvement in palliative and end-of-life care, which the chairs of our national forum group sit on and feedback within our group on. So it's great that the ambulance service is very much has a seat at the table at a lot of these national groups and has a voice. And we've found them to be so excited and so keen, because I think they realise, obviously, in the final year of life, I think the stats are it's an average of 3 ED admissions a patient has within the final year of life. And obviously we're the gatekeeper to the hospitals, aren't we, as an ambulance service? So we can really influence and manage that. So I'm really pleased to say it's really been well recognised nationally, and we are now being invited to these groups and having a voice within this work.
Listen, that's fantastic, and it's a lovely place to finish. Actually, that we are really you're really moving the dial on a national level as well as a local level. So for the second episode, we're really going to do a deep dive into the last year of life and working with specialist palliative care teams, and really dissect what that last year of life looks like, to help people understand the dying phase of life. But listen, it's a pleasure and a real privilege to speak to you, Karina and Jodie, and we'll revisit in part 2 and part 3 different aspects of palliative and end of life care. But I just want to extend my thanks to you both. It's fantastic just to have you both on the podcast.
Thanks for having us. Really enjoyed it. Thank you.
Brilliant. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.